Getting paid adequately by the insurance industry, for one. If you can't afford to spend the time necessary, you can't do it well. Clearly, there's lots of inefficiencies in practice as it exists today, writing notes, dictating notes, working with paper charts, aggregating the data from the charts in order to really optimize the quality of care you deliver is something that we have struggled with for my entire 24 years in practice without finding a very good solution. We've implemented some things in our office, web-based things that we custom wrote to do a better job of refill tracking and lab result tracking, to track hemoglobin A1Cs on diabetics, for example. But none of them have really been adequate, and they're separate, disjointed products that don't talk to each other, so there's redundant work of, I get my lab results from the lab, but then I have to manually enter it into our system, or those kinds of things. So we were looking for a way to tie all of these things together efficiently, seamlessly, so we could move forward. I think it'll absolutely boost the quality. I think people who think it will lower the cost are misguided. But absolutely, I can't see that quality won't improve. I think the final rule is a big improvement over the proposed rule. The fact that we only have to do 20 out of 25, the fact that they've lowered the thresholds from 80% to 40 or 50%, as a first cut at it, makes it workable. Even for things that sound like they should be easy, like recording smoking status on your patients. It seems like it should be easy to get that 80% of the time, but when you're in the heat of battle with the patient and time is limited, that just doesn't seem like the most important piece of information to record, especially in a practice like mine where probably 90% of my patients are not smokers. So figuring out a workflow where a staff member can do that as the patient comes in is probably the better way around, but then you have to build that different workflow. So I think it's definitely helpful. Docs look at the cost of these systems, especially if you don't already have hardware in your office. The cost of doing this, as well as the pain of the transition, is substantial. Being told that you're going to get $44,000 or more per doc makes that pain much, much less. I'm told that the money is actually going to flow from the feds to the states, to the docs, and I'm in New Jersey, where I guarantee you the state legislature is salivating at getting their hands on that pot of money and will do whatever they can do to keep it rather than disperse it to us. But I'm still hopeful. Patients are big time impressed when we walk in the room. We used to use a little handheld PDA for electronic prescribing. Patients were very impressed by that. Now I walk in the room with the tablet, and I'll say to them, so, what brings you in today? And they go, oh, we can talk about that later. Show me what you're doing. I said, well, no, we really don't have time for a lesson here, but it's an electronic medical record system, and we've gone paperless, and they're very impressed by it, and that's good. It makes them tolerate the difficulties of the transition. Until you're really comfortable with the system, you're spending more time looking at it to find things, and normally you'd expect patients to be put off by that, but when you explain to them that this is our new system, they get into it, and they very much like it. When they find out that one of the meaningful use criteria is that they can get copies of their information, I think they'll be even more into it. Of course, that'll probably be a negative for us, as they'll be calling us to try to change things or add things. Our process was probably a little bit different than what a lot of people go through. We're part of the Princeton Physicians Organization, so we wanted to basically build a regional health information network. We're working towards clinical integration. We knew we were going to need to be able to aggregate data from 500 different providers. So I started looking at systems on my own, and then of course they decided we needed a committee to get buy-in from nurses, practice managers, IT people, different specialties. In case you didn't know, the word committee is derived from the Latin for nothing happens quickly. I spent 6 months on my own and then 3.5 years as a committee. But after a 4-year process of looking at a lot of systems, looking at the stability of the company, looking at the quality of the product, looking at how the product evolved as we looked at these products 2 and 3 times over the time as we whittled our list down, we narrowed it down to 3 finalists, and Aprima was the unanimous choice of the 30 or so people on the committee, and so that's how we came to Aprima. The fact that everything is where it should be rather than 200 pieces of paper in a folder, the fact that that I can do reporting, trend the patient's blood pressure and their weight, so I can show them on the screen that as their weight came down, their blood pressure came down, or their hemoglobin A1C came down. Trying to do that on paper is very difficult. There are certain measures. There's a measure called creatinine, which is a kidney function blood test, looking at the reciprocal of creatinine, 1 divided by the creatinine, and plotting that on a graph gives you a much better snapshot look at how a patient's kidney function is declining over time. Well, again, who's going to do that math? When the creatinine is 1.89, nobody's going to do that math and do a paper chart for the patient. It's just not going to happen. But with the computer, you can. So it'll give us capabilities that just were not in reach using a paper system. I think it'll make the time necessary to care for the patients shorter because you won't spend time looking for information in the chart. That'll free up time to address issues with patients that we historically have neglected, health maintenance issues and some of the teaching aspects of care. The ability to have all your patient education handouts in the system so you can attach them to the chart, print them up front for the patient to pick up on the way out, email it to the patient so that they have that piece of paper, because we know they forget 3/4 of what we tell them, or worse, they misremember what we tell them. This way, if they have it on paper, the odds are better. But in the old days, you'd have a filing cabinets full of copies of these things, and it just never happened that the patient got what they should have gotten. So there's so many ways this will make care better, life better. I'm looking forward to that day. We're getting there.
Excellent. That's all we need.
All right then.
Phenomenal.
Do I get a free lunch?